My name's Madi Hankins. I am a genetic counselor here at Lurie's. I work very closely with Drs. Baker and Dr. Prada, and working with some of our metabolic kiddos as well as some general genetics. So I'm super happy to be here today. Was honored that I was asked to come and speak on this topic with you guys. This is one of my favorite conversations to have, talking about inheritance and family planning, because it is a really important conversation to have, not an always easy conversation or a very fun conversation always, but a really important conversation. So thanks for joining me here. I have no disclosures. I've listed some of the things that I'm planning on talking about in the next 45 minutes or so. I do hope for this to be more of a conversation and a little bit more informal, so you guys are welcome to raise your hand, ask any questions throughout the presentation, ask any clarifying questions in case something doesn't make sense. I definitely welcome that. But again, some of the things I was planning on going over are just a really quick primer on kind of the, again, my bread and butter kind of genes and chromosomes. What is genetics? Specifically, what do they have to do with PA and MMA? Some things that Dr. Prada and Dr. Baker already went over, so we should be able to fly through this pretty quickly. And then another just kind of quick primer on broadly how does genetic testing work? And then specifically, once we kind of go over the genetics and inheritance, what is the inheritance of PA and MMA, and then more specifically into kind of what family planning options are available to individuals or families with PA and MMA, and then kind of lastly, when should children be evaluated? So again, just a really quick brief basic primer on the basics of genetics, just so that we can all get on the same page before I jump into some more of the family planning topics. If we're kind of probably throwing this back to some high school biology, but really broadly, I think about our DNA. Every cell in our body contains our DNA. It's housed within our chromosomes. If you take an even closer look into those chromosomes, you're going to find our genes. Our genes are what control our bodies and tell our bodies how to look and how to work and how to function. We have two copies of each of our genes, kind of broadly. One copy that comes from the maternal parent, one copy that comes from the paternal parent. So again, just important information to kind of bring along with our discussion of the genetics of PA and MMA. So again, Dr. Baker already went through this very well, but if we think about the genes specifically associated with PA and MMA, PA can be caused by errors in either the PCCA gene or the PCCB gene. Errors in either one of these genes will create a deficiency of an enzyme that, again, he already named, and I won't butcher because it won't be pretty, but I did put it up here on the slide for you guys. But this enzyme, I think about it just like as a chemical that's within our body, is responsible for breaking down parts of proteins and some parts of fats. Similarly, MMA, primarily, like Dr. Baker said, is caused by errors in this MUT or MMUT. It's kind of, the names are used interchangeably, but can also be caused by some of these other genes less frequently. Again, errors in these genes result in a deficiency of a different enzyme, but that's also responsible for breaking down proteins and fats. I'm a very visual learner, so I like to kind of put pictures to different concepts that I think about. So I think about kind of the role of an enzyme as a crowbar, and if we think about our proteins and our fats as kind of these Lego pieces that you can put together, the crowbar is responsible for breaking apart those Lego pieces. Without the crowbar, or without kind of a functioning copy of that crowbar, those pieces of Legos are going to accumulate within our bodies and can ultimately cause issues. So if you saw the slide and you're like, what the heck is a crowbar and Legos doing on it? That is kind of a quick look into my brain. So hopefully maybe it's helpful for you as well. So thinking about all these genes being important for proteins and fats. Ooh, I didn't even know I had a thing on there. Without functioning copies of these genes, again, these levels of certain substances, going back to those Legos, are going to accumulate and cause cause difficulties in the body with different functioning areas. Which again, this nice diagram was also echoed in Dr. Baker and Dr. Prada's slides. So then moving on to the specific inheritance of PA and MMA. Again, I think many of us are going to be familiar with it, but wanted to take just a quick look. So we know that PA and MMA have an autosomal recessive inheritance pattern. Really all this means, and you can kind of think about it as opposite of autosomal dominant inheritance patterns, but autosomal recessive inheritance patterns means that there are two changes required in each copy, or one error required in each copy of the given gene in order to have the condition. So again, this diagram, kind of nicely lays it out. Typically when we see a child that has PA or MMA or any other autosomal recessive condition, we expect that their parents would be carriers. So carriers meaning that they only have, I don't know if I can use my pointer, I cannot, okay. Carriers meaning that they only have one changed copy of the gene while their other copy is functioning. So they wouldn't be expected to have any symptoms of the condition, but again, they are capable of passing on that genetic change to their children. So I think some common questions that kind of come up when we're thinking about autosomal recessive inheritance obviously are going to be, if two parents already have a child with PA or MMA, what's the risk to each future pregnancy to have another child with PA or MMA? From this diagram, we know that it is going to be that 1 in 4 or a 25% chance. I think important to note, and kind of a common misconception, that this 25% chance or this 1 in 4 chance repeats every pregnancy. So just because you've already had one child with PA or MMA does not mean that you've kind of fulfilled your 1 in 4 quota. That is going to repeat every pregnancy. So I think, a really important kind of distinction to make there with that number. I think the next question that kind of comes up with this pattern of inheritance is, if somebody has PA or MMA, what's the risk for their future children with PA and MMA? This one gets a little bit trickier because it is going to depend on that other partner and what their carrier status is. So, someone again with PA or MMA is going to be guaranteed to have those two change copies. So no matter what copy they're passing down to a future child, it is going to be that changed copy. So kind of different from this diagram right here, every child that they're going to have is going to be at the very least a carrier, meaning they're going to have that one changed copy of the gene. And again, what their full risk to their future child would be really is dependent on, again, their partner. So whether or not their partner is found to be a carrier. So kind of as you're having these conversations with your kids or, with other family members, kind of talking about the recommendation that future partners also be tested for the given condition to, again, kind of better understand their carrier status. If on the off chance that partner is found to be a carrier for PA or MMA, the risk then again becomes that 1 in 4 or that 25% chance. Lastly, I think, a common question that comes up, or a common thought that comes up with autosomal recessive conditions is, well, nobody else in my family has this condition. Where on earth did it come from? I think what we frequently see again with these autosomal recessive conditions is that there are just many people in the family that are carriers, and just no one ever kind of happened to get with another carrier and reproduce such that they then had a child with PA or MMA. So I think that, really highlights the fact that once you're found to be a carrier for PA or MMA, it's absolutely recommended that your family members can also be, or should also be tested for the given condition, because it's highly likely that they may also be carriers, and then, will be at risk for a potential child with the condition. So moving on, so now that we've kind of laid the groundwork with genetics and the genetics of PA and MMA, I wanted to talk about testing for PA and MMA. A lot of family planning options are available for individuals with these conditions, which again I'll get to in a little bit, but really it's important to be able to pursue those conditions that you know what the genetic variants that are in your family are, because that's what we then would have to test for in order to pursue those family testing options, or family planning options, excuse me. So when we're talking about testing for PA and MMA, we really would be remiss to not bring up the presence of newborn screen. Again, if you have a child that is under kind of that 20 or so years of age, likely the way that they were ultimately diagnosed was by being flagged on the newborn screen. For anyone who isn't familiar with the newborn screen, this is a screening test that is performed from about 24 to 48 hours of life on newborns that are born in the hospital. It's often called the heel prick test, so it is, baby's little heel is pricked to get a little blood spot, and then that's what the testing is then done on. There are many conditions that are on the newborn screen. This is dependent on what state your child is born in. It will vary from state to state, so I think certainly important to note that. Pretty broadly across the U.S., many metabolic conditions are on most states' newborn screens, so I think we've really come a long way in that area. But kind of the distinction about which conditions are included on the newborn screen really comes down to kind of these more severe conditions that do have a treatment or a medication that can help improve a child's life if given early on in life. So that's the newborn screen. Again, like I said, many metabolic conditions are on there. PA and MMA were added to the Illinois newborn screen specifically back in 2002. So again, if your child or family member is under kind of 20 or so years of age, likely this is how they came to clinical attention. It's important to note that the newborn screen itself isn't a genetic test. It is a screening test. So it just tells a provider that there is a higher likelihood of a child having a condition, which then warrants additional workup. So again, likely if you guys have been through this process, you likely got a call from your pediatrician that said, hey, you need to go to genetics to get some additional workup. Likely that workup included some genetic testing. So again, just to kind of lay the groundwork there for genetic testing in PA and MMA. Really just kind of briefly taking a broad look at genetic testing for PA or MMA. I would always recommend that either a genetics provider or a genetic counselor be involved in this process, because as you can see, there are kind of a lot of steps, and there's even some additional kind of shoot-off steps from these. So having someone experienced that is doing this day in and day out is really recommended. But typically, we'll recommend getting insurance prior authorization for genetic testing. We've come a long way with the cost of genetic testing, but it does tend to still be pretty expensive. So getting that authorization from insurance beforehand is recommended. We'll then collect a sample. This can be blood, it can be saliva, it can be a buccal swab, so a kind of a Q-tip that will be rubbed on the side of your cheek. It's then sent off to the lab to be analyzed, and then once the results are back, those will be shared with your genetic counselor or provider, who will then discuss the results with you. Again, because some of the kind of shoot-offs from this process, insurance may not approve genetic testing. So having someone experienced to be able to kind of walk through what that denial might look like, submitting an appeal on your behalf, because obviously if we're recommending genetic testing, should be clinically indicated. So again, being able to walk through that appeal process, or if ultimately it still remains denied, to be able to talk about out-of-pocket costs, because I think we've also come a really long way in being able to make affordable out-of-pocket non-insurance payments for insurance. So would always recommend following up with a genetic counselor for genetic testing. I think it's also really important to note that even if we are doing genetic testing, the results aren't always straightforward, and they don't always give us a kind of slam dunk yes answer, as much as we would like that to be the case. So some of the results that we can get when we do genetic testing, even in children or individuals that we highly suspect have a given genetic condition, can be variable. So, again, the best case scenario is that positive result. So identifying 2 genetic changes in a given gene that say, yes, this is the condition that your child has. Sometimes, though, we still get a negative result. This really comes down to the fact that genetic testing still isn't perfect. It doesn't necessarily rule out a genetic condition just because we can't identify the genetic cause or the genetic misspellings. So I think, again, something important to consider, but, to recognize that could be the result of genetic testing. Also, a result that can be fairly frustrating is this variant of uncertain significance. It's a mouthful. You can also call it a VUS. You may have heard your providers calling it that. Essentially, what this means is that we find a misspelling in your child or family member's DNA that we just don't understand the significance of. So we know the misspelling is there, but we don't know if it's a misspelling that certainly causes PA, or actually it's just a misspelling that doesn't cause any issues in our bodies. I like to use the example of gray versus gray, G-R-A-Y and G-R-E-Y. You still know what the word is, you still know what it means, but the letter is still misspelled. Our DNA has these too. We all have these, but they don't cause issues in our body. So sometimes, again, we get those results that we just are not able to push one way or the other. So again, I'll be tooting my own horn, but another reason to consult with a genetic counselor when you're getting genetic results so that they can kind of go over some of these more intricate results with you. Okay, so we have laid the groundwork for the genetics of PA, genetic testing for PA and MMA. Now moving on to kind of the bulk of the conversation and family planning. I'll start off this section by saying that family planning is always going to be a really personal decision for families. There is no right or wrong way to either start or expand your family. So, I really just, again, want to throw that out there as you're kind of starting to consider these options, if these are options that you are considering, to be able to say, again, no right or wrong way. So just, I think I would encourage everyone to keep an open mind as we're thinking about these. So as I said, there's many different ways to have a family or to expand a family. We can think about natural pregnancy, so pregnancy the old-fashioned way, pregnancy with the use of assisted reproductive technologies. We can think about donation, so whether it be an egg, sperm, or embryo donation. And we can also think about adoption. Certainly there are more options outside of these, but these will be the ones that I'll be covering today. So as we're starting to think about these options, I think it's really important to orient ourselves and say, are these options that we're even interested in considering? Are these going to be options that are going to be right for myself, my partner, my family, in order to expand or to start our family? So again, as you're thinking through these questions, kind of questions to ask both yourselves and your partners, how would I feel if my child had PA or MMA? Alternatively, how would I feel if another child had PA or MMA? Would I want to know if a pregnancy had PA or MMA? I think a common misconception when it comes to kind of testing during a pregnancy is that the only reason to test during a pregnancy is so that you can consider termination. Certainly that is a valid reason to consider genetic testing during a pregnancy, but there's also a lot of other very valid reasons to test during a pregnancy. One being able to plan and prepare. There are different things that you'll need to do to be able to have a child with PA or MMA, certain doctors that you'll want to put in place, different maybe kind of family support systems that you'd want to put in place. By being able to know during a pregnancy, you can then do those things. Maybe it's just to decrease anxiety. You don't want to wait 9 months to figure out if your child has PA or MMA. That would be really hard. You're already waiting for a child. You're not wanting to put an extra kind of thought process or question on top of that. Important to note, just kind of given the political climate, that termination is not something that's available in all states. So I would just, on all of these points, encourage you to talk to your guys' providers about kind of what things would be available to you based on where you are living. Once you go through these questions, the question remains, would I rather consider alternative ways to have a family so that my child would not inherit PA or MMA? Before I jump in any further, I think it is important to note that there has not been a lot of research done in kind of the areas of how families or individuals feel about the process of thinking about family planning with PA and MMA. I think kind of delving into different psychosocial or psychological considerations, because there are a lot that go into this process, as I'm sure anyone who's already kind of been through the process or is currently considering the process can attest to. So I would love for there to be, more research in this area. So certainly if a research opportunity like this were to present itself to you guys, would encourage you to participate, because that's how we learn more about the field and about different considerations. So now moving into some of the different testing modalities. So we talked earlier about being a carrier for PA or MMA, again, something that many of you are probably very familiar with. I think important to note that carrier testing should be offered to anyone who is considering pregnancy or is currently pregnant. This often can be coordinated by your OBGYN or pregnancy provider. It is the ACOG and ACMG, so the American College of Gynecologists and the American College of Medical Geneticists. Yes, too many acronyms, that any couple be offered this testing, because it is relevant, obviously, for recurrence risks. Definitely kind of in our context, it's going to be relevant for PA and MMA, but important to consider whether or not you would also want to be tested for other conditions that you may not know run in your family. Typically this is done as a blood test. It can also sometimes be done as a saliva test. And again, like I said, so thinking about whether or not you would want to kind of just test for the familial variants if you haven't been already, or if you want to test for many, many, many more conditions. So there are dozens and dozens of conditions, autosomal recessive conditions, that can be included on this panel. So again, just kind of thinking about what's going to be best for you and kind of what information you would want to have either during a pregnancy or moving towards a pregnancy. So here I've included some testing options that are available during a pregnancy. So whether or not the pregnancy was done naturally or done via IVF, testing options that are, again, available during the pregnancy, so that you can determine, does this child have PA or MMA? The first option is this chorionic villus sampling, also referred to as CVS. This is it's an option that's available earlier in pregnancy, so typically it's done between 10 and 13 weeks. So certainly if we're thinking about those couples who are more anxious, want information sooner, this could be a good option. Additionally, also important to note that because it's being done earlier in the pregnancy, it's likely going to be a more private option. So, for anyone who's not familiar, within your first trimester, you're less likely to have some of those outward signs of being pregnant. So, likely your coworkers wouldn't know, extended family wouldn't necessarily know. So it allows a couple to, again, kind of be able to make more of these decisions in private, should that be something that you guys are wanting. How the procedure is done. So these both are invasive procedures. CVS specifically is done via a needle through the belly or through the cervix, which gets a little piece of the placenta. The placenta is kind of one of the areas in the abdomen that are providing the baby with nutrients, and shares the DNA with the pregnancy. So being able to get a little piece of this placenta enables us to kind of directly test the fetus's DNA. Because this is an invasive test, it does come with a risk of miscarriage. The risk is estimated to be about 1 in 200, so less than a 1% chance, but still prevalent. The second option, also an invasive procedure, is called amniocentesis. Similar technology. This one is only a needle through the belly, which instead of a piece of the placenta, grabs some amniotic fluid. So again, this is kind of the fluid that fetus is floating around in. If you think about kind of like if you're in the shower loofahing, some of those skin cells are going to be sloughing off and getting in the water. That's what's happening with baby with the amniotic fluid. So some of baby's skin is coming off into the amniotic fluid, and then being able to collect that, we're then able to directly genetically test that and then determine if baby has this condition. This one also carries a risk of miscarriage. This one is about 1 in 900%. This is less to do with a kind of difference in procedure, but more to do with just the fact that you are further along in your pregnancy. So there's just generally a lower risk of miscarriage because, again, you're further along. Both of these tests are diagnostic, meaning that it can give you a yes or a no. Baby has condition, baby does not have condition. Opposite, or not opposite, but slightly different from diagnostic testing is something called screening testing. So screening testing gives less of a yes/no and more of a you're at higher risk or you're at lower risk. We would recommend some more testing. This test is called cell-free DNA test, or NIPT or NIPS, or NIPS. Again, the acronyms are getting me. You may have also, this is a pretty commonly used test. You may have also heard this referred to as the gender test. That's not what it is, but it can tell you fetal sex early on in the pregnancy. This test is minimally invasive, so it is just a blood test on mom. The technology behind this test is that within mom's bloodstream, there actually are kind of small fragments of DNA from baby that are kind of peripherally there. So because we're not testing baby directly like we are with the amnio or the CVS, it's not, again, it's a screening test. It doesn't give us that direct yes or no because, again, we're not directly testing baby. This can also screen for other conditions. Commonly, it's used for chromosome abnormalities like Down syndrome. It's a really good test for being able to screen if a baby is at higher or lower risk for Down syndrome. Unfortunately, at this time, this is not a test that is able to screen for PA or MMA, nor is it available for many monogenic disorders or disorders that are caused by one gene. But certainly, still something to consider in your pregnancy, just for the potential to screen for other disorders. So this briefly is just kind of a workflow of kind of what that would look like. So you get the screening test. If you get a positive, we would say this is a higher risk. So you're at higher risk for a given genetic condition. We would then recommend that diagnostic testing via amnio or CVS. Or you could get a negative, which means you're at a greatly reduced risk of condition X, and you don't necessarily need to pursue additional testing. So again, as I mentioned, this is not something currently available for PA or MMA. There is a lot of research kind of generally into monogenic disorders and how we can use this really easy, really simple technology to look for more conditions. But again, the technology is just not quite there yet. So this was a statement done fairly recently back in 2021 that again states that we just don't have enough data. But hopefully kind of down the pike it is something that does become more available for more disorders. Okay. So that's all testing that can be done during the pregnancy, some done a little bit before the pregnancy, but ultimately some people still decide to use assisted reproductive technology to become pregnant and also to be able to consider screening embryos for PA or MMA. This is the only way currently to be able to test an embryo before pregnancy. We do always say that even if you do end up pursuing this option, we still recommend genetic testing after baby is born, just for further confirmation. So for some of our assisted reproductive technologies, we have this pre-implantation genetic testing for monogenic single gene defects, another mouthful. This can be referred to as PGTM. This was also previously referred to as PGD, so you guys might be a little bit more familiar with that. Essentially, this, again, is genetic testing of embryos for a given genetic condition or for a given familial variant. This is done in conjunction with in vitro fertilization, so IVF. So you've probably also seen it as IVF with PGD, because again, we love our acronyms. And this technology actually has been around for a while. So the first instance of IVF being done with PGTM happened back in 1990. So again, we've been doing this really successfully for about 30 years or so. I in no way want you guys to think that this is a particularly easy process. I think it's super important to point that out, that this does create a burden for all family members involved, particularly the maternal parent. So typically, or essentially how this process works is mom receives a hormone to stimulate her ovaries to produce more eggs than would typically be produced. The doctor will then perform a procedure which collects those eggs, Meanwhile, the biological father or paternal parent will provide a sperm sample. In the lab, those two, the sperm and the egg, are then combined together to be fertilized, and then genetic testing is done on that developing embryo. So just taking a really quick, faster, or really zoomed in look. Here we have the eggs being retrieved from biological mother. We then have the process of that fertilization. So this is also referred to as ICSI. So again, the egg being combined with sperm. Again, then the embryo is allowed to kind of reproduce for a couple of days, at which point that biopsy is then obtained, which then can have genetic testing performed on it. Typically, the kind of entity that will be coordinating all this would be a reproductive endocrinologist. So, I talk about it. There's definitely prenatal genetic counselors who can talk about it, but kind of the individuals performing this process would be a reproductive endocrinologist. So, definitely if there was more questions or, additional kind of thoughts, the place to start would be your OBGYN or your pregnancy provider to kind of make a referral to one of these providers. Also at this last step, so when we're looking at the embryos and testing them for a given genetic condition, we're also looking at the embryos to make sure that they're kind of structurally sound, that there's not some other abnormality in the embryo that would prevent it from resulting in a healthy pregnancy. At this point, once the eggs are retrieved, families will then kind of make various decisions about what they want to do with the eggs. Important to note that not every round of IVF with PGD will result in a viable embryo. Some families do have to undergo multiple cycles in order to get an embryo that's both healthy and without a genetic condition, if that is what they are interested in. Assuming that you are able to get one with kind of the attributes that you are looking for, again, families kind of make different decisions on what they do with the extras. So there are different options to freeze, there's different options to donate to other families, there's different options to donate to research. So I think lots of different ways that kind of families will proceed based on their choices. Just as IVF with PGT is not an easy process, nor is it a cheap process. So in the US currently, the average cost of IVF with PGT is about $17,000 to $25,000. Interestingly, you can see here from the table, it really isn't the genetic testing that poses the greatest cost. It really more so is the procedure to obtain eggs from mom and also all the medications that she'll be having to take beforehand. I do want to point out that there are a good handful of states that do currently require insurance companies to cover IVF based on infertility in a couple. Cover or partially cover. Infertility in a couple specifically is being unable to get pregnant naturally for at least a year. Now, certainly this doesn't necessarily extend to families who aren't experiencing infertility, but just want IVF due to a familial mutation. So a smaller number of states than those that do cover infertility also have line items for families who are interested in this due to familial mutations. So again, definitely if this is something that you are interested in looking into or considering, would begin to kind of look at your insurance coverage, look at your kind of state legislature to kind of see, what is the kind of what is going on in your state or in your particular situation. So again, another really good option is donation. So this allows the maternal parent to still become pregnant and still be able to experience the experience of pregnancy, but without, again, kind of the risk of passing down to genetic mutations. This still kind of unsurprisingly is still not very cheap, specifically egg donation, because you're still going through a lot of the processes that are involved with IVF with PGD. So the average cost for an egg donation is about $30,000. Receiving a frozen egg donation is a little bit less. So again, thinking about families who had extra embryos had extra eggs that they didn't end up using, decided to freeze and to donate to other families, kind of lessens that cost. And it's a similar cost for the same process for donor embryo. Sperm donor is cheaper because the process is a little bit easier. There is not the large procedural burden with sperm donation, and then the way that this would be implanted is via intrauterine insemination, in which it's kind of placed in the woman's uterus. And lastly, adoption. Adoption is another really lovely way to either start or expand a family. Still not without burdensome costs. Being transparent here, you guys. So there are still many ways to pursue adopting a child with kind of varying associated cost. Typically, the average cost in the US at this time is about $43,000, and there is kind of a successful match rate of about 2 years. So a little long, a little pricey. But again, lots of different options for different kind of international adoptions. This is going to vary country to country, kind of with cost. Another really good option is this foster care to adoption. So kind of going down the foster care pipeline is a little bit less. There is a really nice organization, the Adoptive Family Survey, who every couple of years does a survey of adoptive parents and kind of asks them about their experience. So one of the questions that they posed I thought was really helpful, and kind of how did you as a family, how are you able to afford the adoption that you underwent? So I think, lots of different kind of options to consider. So, taking advantage of different tax credits, taking advantage of different loans, GoFundMe's, there's all sorts of different options, but obviously, or certainly also, thinking about different things that your employer offers. So there are different employers that will offer adoption or IVF stipends. So, again, if nothing else, kind of going away from this talk is if any of these are things that you're interested, start looking into options. There are likely options out there that you just may not be aware of, but that might exist. So, do some research, kind of look into it so that you have a better understanding of what's out there. Okay, so we're getting to the end here, I promise. So we've gone through the different kind of family planning options, and then now kind of again going more into kind of how does this affect our children who may be at risk to have PA and MMA. So we talked about the different screening and diagnostic testing options. We talked about the different assisted reproductive technologies, donations, adoptions. There's also the option to not do any of this, to pursue a natural pregnancy, to not pursue any genetic testing, and to just wait and see. As we've kind of talked about, the workflow of this would include newborn screening and evaluation. We do know that it is of the utmost importance that children be evaluated as soon as possible so that they can then be treated as soon as possible. So really, I think this is a just a shout out for your metabolic teams, is that if you are pregnant or considering a pregnancy, just to let your teams know so that there can be a birth plan in place, tongue twister, so that again, any child who's at risk can then be evaluated as soon as possible in conjunction with newborn screening. And then, as I mentioned here, all of that will be happening, and then ultimately baby will then be likely tested for the genetic variants to get further confirmation. Okay. So review. Parents of children with PA and MMA, as you've now heard probably 4 or 5 times today, and as you probably already knew, have that 25% chance to have another child with a condition. Lots and lots and lots of options exist. Children should be evaluated as soon as possible. If, again, nothing else, genetic counselors and your metabolic care team are your friends and greatest resource as you are kind of going through all these options. So a big shout out for, all of your providers to, talk about these with them. This is my job. This is what I do every day, is kind of talk about these things with families and help you all process these options and what would be best for you. So will toot my own horn one more time. If the center that you're at currently does not have a genetic provider, or there's not a genetic provider in your area, I would always encourage anyone with questions to reach out to a genetic counselor. There is a fabulous Find a Genetic Counselor on the National Society of Genetic Counselor website. So again, if that's something that you are interested in and want more information, I guess I'm done. No, I'm not quite done. Don't go. I know. You guys watch out over there. On that note, thank you. But any questions or comments? Catherine, we have one in the back corner.
This is Brittany Smith with the PA Foundation. I just want to make a comment that if anybody is looking into adoption, we adopted our 4 kids. It did not cost anywhere close to what that was on there. But as with anything, that's where our child with PA came from. So we've had multiple families that we do know of that had that adopted children with PA, with knowing and not knowing.
Yes, awesome point. Yeah, definitely an average. I think it'll totally depend on where you're located, kind of what agencies you're going through. So, again, look into your options. There are options. Look into them.
Nicole Russell, I'm from Wisconsin. I have 2 kids with PA. I have a 12-year-old boy and an 11-year-old girl. We also have 2 other kids. We have an 8-year-old with cystic fibrosis, and we have a 2-year-old that's not affected by any of it. And with our 2-year-old, we did do PGD or IVF PGD. That's what they called it back then.
Yep.
2 years ago. It's changed.
It's always changing.
And I'm happy to talk to anybody that's thinking about the process. It took us over 2 years to have him, to go through the process of testing embryos, and we went through about 3 rounds of IVF. So the number that she showed up there, multiply that by 3. And I also was very successful in getting my insurance to cover all of it. So I wrote letters to United Healthcare. I explained to them the cost of having children with PA and CF, and the cost that essentially what it would save them if I had another child with that disease versus paying for my PGD and IVF, and they finally covered it. So it took a time, but I wrote the letters and I did the due diligence and the back end work, and we have a baby that's not affected by it, and he's fantastic. So feel free to reach out if anybody has any questions on it. And it was tough, but we're blessed.
Yeah, thank you for sharing that. And I think that is another really good point, kind of depending on which providers you guys are using to pursue this, if it's at a reproductive endocrinologist, likely they have an insurance professional who's doing this day in and day out. So, definitely leverage all the resources you have, have an additional resource. You said you were from Wisconsin. Okay, so, maybe functioning within the Wisconsin system. That's awesome. Thank you for sharing.
Yeah, so I have a 28-year-old, and this is his brother. He's 25, so we're actually getting ready for the next generation.
Yeah.
And I know there is possibility of him being a carrier. So looking into options of what would be best for him as to move on to, having a family, would the insurances kind of accept, or do you have any experience of anybody going through that and, saying, hey, I have a brother and there's a good chance that I could have a child with PA too, so would they be willing to consider if that is an option for them to cover, like the IVF with PGD?
Absolutely, yeah. So, definitely where we would say, where to kind of start the process is find out, given your family history, if you even are a carrier, that's going to be the first place before even kind of, going down the road of IVF. Is that something that you even need to do? Certainly, again, all day long, I'm making the case to insurance companies about why this testing should be covered. Absolutely, the first thing that I would mention is, well, there's this family history. This person is at a whatever percent risk of having this genetic change. This is why genetic testing should be recommended. So I would certainly be hopeful that that would be something that would be covered. we never say never with insurance. It's the bane of my existence, but I would certainly be hopeful that that would be something that would be covered, and that would be the best place to start.
Right, yeah. And is there some sort of like, I know that I've had a lot of problems explaining this entire situation to someone who I've been dating or things like that.
Yeah.
Is there any sort of resources that you have for that?
Ooh, that's an excellent question. Yes, absolutely. So, one thing that you could also consider, toot the horn again, is meeting with a prenatal genetic counselor. It shouldn't be entirely on you to have to explain it to a partner and kind of explain all the ins and outs. That's also something that we do. So, considering meeting with a genetic counselor, but also, yeah, definitely just kind of, providing with some resources of this is what PAR is, and kind of going from there. That's a great question, because those are difficult conversations to have.
Definitely, yeah, thanks.
I'll just share a little bit of experience I've had with from siblings
And this is
who are
Catherine. She's
carriers.
also a
I'm
genetic
also one of the
counselor.
genetic counselors. I've had siblings ask me to write a letter with some basic information about the condition and what it means to be a carrier, and so that they could share that letter with prospective partners. And so genetic counselors are happy to do that. So that's something you can request from your provider, your metabolic team, or your genetic counselor, is to write something like that for you to share, because it is very difficult to even bring up this conversation and have a discussion like this, and let alone find this right words and terminology to use to explain the condition to someone else. So we're happy to help facilitate that process. That's always a personal decision. There's no right or wrong answer in deciding if you want to know your carrier status. That is a personal decision that we think should be left up to the individual to make. I will say that if you want to do carrier testing because of a family history, it is most informative when you have the known genetic changes in the affected individual. So the first person that needs to get genetic testing is the actual person in your family that has the condition, so that we can identify their correct genetic changes, and that information can then be used to do carrier screening for at-risk family members. So for some individuals who got their diagnosis 25 years ago, 26 years ago, they might not have done genetic testing then, because the genes were only for PA and MMA only recently discovered. So if your family member with the condition is older and has not had genetic testing, we would want you to seek that out from your metabolic team.